Good morning or good afternoon. Today we're going to go over clinical reasoning. This will be a flipped lecture today. So our objectives are we're going to define clinical reasoning, also called professional reasoning. We're going to explain what is meant by the three-tracked mind. We're going to describe the types of reasoning used by occupational therapy practitioners. This includes procedural, interactive, conditional, pragmatic, narrative, and deductive reasoning. We're going to explain how each type of these reasonings is typically used. And the idea is we're going to hopefully apply this reasoning strategies to a case study next class period. So we have the three-tracked mind. So the concepts or the OT practitioners use different types of reasoning during the actual intervention process. Different types of reasoning accomplish different goals. And there's three different types. There's procedural, interactive, and conditional. And we'll touch on each of these as we go throughout this PowerPoint. So we have procedural reasoning. So some descriptors are we're looking for cue identifications. So problem identification and treatment selection seen as central tasks. So looking at the sequence of diagnosis, prognosis, and prescription. This is very medical based. Then we have hypothesis generation. This is often creating multiple competing hypotheses regarding cause and nature of aspects of new problem, but also about potential treatment activities. This happens with experienced therapists. With a new therapist, they typically have tendency to seek the right answer rather than generate a hypothesis. And abstract thinking can be very helpful with hypotheses generation. And we're using heuristics. So these are guiding to how we learn and problem solve. These are mental shortcuts that allow people to solve problems and make judgments quickly and efficiently. Rule of thumb strategies to shorten decision-making time and allow people to function without constantly stopping to think about their next course of action. We typically use these considering the disease or the disability presented. So if you have a hip replacement, you'll have to use a reacher. So it's impersonal and very diagnostic driven. And this decides on our intervention methods. So the example of if you have a hip replacement, then you'll have to use a reacher. We all know that typically that's not how it typically goes. And then the thought process is we're identifying the problem, so that function, dysfunction, as well as a diagnosis. So think of like multiple sclerosis. We typically will do energy conservation techniques, although not all clients could benefit or would benefit from energy conservation techniques. We're then selecting intervention techniques, either compensatory or remedial methods. Then we have interactive reasoning. So some descriptors are we're valuing the client as a person. So it's an illness perspective. So contrast with a disease perspective of the procedural reasoning. We're related to humanistic values. There's more complex than formal education and relies on what we call interpersonal intelligence. So this relies on a strong sense of self, relates to therapeutic use of self, as well as the intentional relationship model and cultural competency. So all that stuff's coming into play here. It's related to professional competence and competency and can be more difficult as a novice practitioner. Typical use is you're understanding and relating to the client. You're building that trust. You're establishing the client-centered context. You're building a rapport. Like I mentioned in class, rapport is probably your strongest skill that you need. And it's related to the client's experience throughout the intervention process. So the therapist is concerned with what the client likes or doesn't like. You use praise, empathetic comments, and nonverbal behavior to encourage and support your client's cooperation throughout the process. The thought process is largely intuitive versus an analytical thought process, and it's that utilization of those nonverbal cues as well. Then you have interactive reasoning, which we're engaging the person in the treatment session. We know the person as a person. We're understanding a disability from a patient's point of view. We're finally matching treatment goals and strategies to a patient with a disability and experience. So we're individualizing that treatment. We're communicating a sense of acceptance, trust, and hope to the patient. We use humor to relieve tension. So therapeutic use of humor, as well as construct shared language of actions and meanings. and determining if the treatment session is going well throughout that process. So then we have conditional reasoning. So some descriptors are tends to develop with experience. So who can see multiple futures based on past experiences? You know what questions to ask based on an experience of an individual. It's a blend of procedural and interactive reasoning, and it uses a shared image of the client's future self. So typical use, it's that what if question that you're trying to answer. What might change the current conditions? We're looking at possible outcomes of therapy. So we're looking at immediate concerns, then deeper level interpretation of the whole problem. Its thought process is we're considering the current and future context of the client. We're comparing the current status to the desired status of the client. We're using interpretation and imagination, and we're considering possible developmental patterns of the problem. So therapists is thinking about the whole condition. So we're looking at the person, the illness, what it means to the patient, their family, their social circle, as well as their physical context. As far as imagination, therapist thinks about how the condition could change, how that condition is more fluid, how it could change a week from now, 2 weeks from now, a month, or a year. And then as well as those developmental problems, therapist thinks about the success or failure of treatment being contingent on the patient's participation. Then we have narrative reasoning. So the descriptors of that is we're putting intervention tasks into a meaningful context. So we're looking at the current context as well as related to a future vision of that patient. Its typical use is part of a rapport building and keeping a client engaged. And we're really focused on the client as well as it captures the client's interests. Its thought process is storytelling. We then have pragmatic reasoning. Some descriptors of this is we're addressing ethical dilemmas. We're prioritizing intervention goals. We're using our scope of practice as well as best practices. More often than not, there's those evidence-based practices. Typical use is it considers the practical aspects of practice. So we're looking at ethics, reimbursements, and regulations. So treatment is focused around the payment, the schedule, and the realities of the service delivery. Its thought process is through the code of ethics and ethical guidelines. We're looking at third-party payers, the Practice Act, as well as AOTA standards of practice. Then we have factors requiring pragmatic reasoning. So relations with colleagues, role boundaries, nursing to support follow-through. We're looking at scheduling, so kind of that frequency and duration of sessions, availability of space and supplies, organizational norms and policies, time, as well as overall supplies. We're looking at number of clients, so those kinds of clients that we're seeing, the prioritization of those clients. Are they insured or are they self-pay? The place and timing, the caseload, the payment, as well as discharge options as well. So then we have deductive versus inductive reasoning. So inductive reasoning, we're given the evidence available. What can we reasonably infer about a pattern or predict about a future event? So we're extracting a premise or a hypothesis based on observations. We need to make sure that they are complete observations for an accurate hypothesis. Then with deductive reasoning, the conclusion follows inevitably from the premise. So it starts out with a general statement or a hypothesis, and it examines the possibilities to reach a specific logical conclusion. Often we use both of these in practice, and they're often used simultaneously. So putting it all together with the three-tracked mind, we're looking at procedural, which guides the therapist in thinking about the patient's physical performance. We're then looking at the interactive model, when the therapist wants to understand a patient as a person. And then we're also looking at the conditional, where we're used to project or imagine a future for a patient. Additionally, we are also using the narrative, pragmatic, and deductive inductive reasoning as well. A lot of stuff going on. Some clinical reasoning developmental stages. So we have our novice therapist, so zero years of experience, and we have our advanced beginner, which is a little bit less than or equal to a year. We have our competent, which is about 3 years experience, proficient about 5 years, and expert about 10 years. So this does come in time. Clinical errors. So they can and will happen, but why? A lot of times they're biased evaluations and effects of secondhand information. Oftentimes they're exaggerated impressions of social supports. Too few cues or too many are given during an eval. Inaccurate interpretation of cues and data. Premature closing of reasoning. Or using one source of evidence instead of using multiple sources. We then have the idea of trauma-informed care. So trauma refers to extreme stress that overwhelms a person's ability to cope. This definition is an intervention organizational approach that focuses on how trauma may affect an individual's life and his or her responses to behavioral health services from prevention through treatment. This is a special licensure that you can get as an OTA. You can become a trauma-informed OTA as well. Then we have the idea of evidence-based practice, often referred to as EBP. This blends three things: published evidence of an intervention's effectiveness, the clinical experience of the practitioner, and the expertise of others, as well as the values, goals, preferences, and wishes of the client you're actually treating. That is the end of our PowerPoint. Come with questions. I will plan on doing a review like I've always done, as far as the content within this. And then we will work on a case study next class period involving all these things. Hope you guys have a great rest of your day, and I will see you guys next class period.